Welcome to Anesthesia Updates. Always better to learn from others' mistake to improvise ourselves. This video explains a case scenario landing up in complication and a lesson learned from it. A 2-year-old, previously healthy girl, 16 kilograms, is scheduled for endoscopy and removal of an esophageal web. Her medical history is unremarkable except for mild dysphagia. Her vital signs are normal. General anesthesia is induced via face mask using sevoflurane 1 to 4% in nitrous oxide and 30% oxygen after all necessary monitoring equipment is placed on the child. After the child is asleep, an intravenous IV line is inserted, and 0.15 mg atropine and 1.6 mg vecuronium are administered to facilitate tracheal intubation with a 5 mm internal diameter (ID) tracheal tube. Breath sounds are equal bilaterally, and a leak around the tube in the trachea is present at 20 cm of water peak inflation pressure. The endotracheal tube is securely taped. The patient's lungs are hand ventilated using peak inspiratory pressures of 15 to 35 centimeters of water. The patient is draped from the neck down, and the endoscopist places the gastroscope into the esophagus without difficulty. A few minutes later, the lungs become less compliant, and the child's blood pressure, BP, decreases over a 5-minute period from 90/50ths to 70/35ths of a millimeter of mercury. The electrocardiogram (ECG) is judged to be normal, and the heart rate increases from 110 to 130 beats per minute with a regular sinus rhythm. The capnograph demonstrates a County 2 waveform. The shape has not changed, however, the peak airway pressure now increases from 22 to 38 centimeters water. The peripheral oxygen saturation decreases from 100% to 86%. You do the following: 1. Increase the FiO2 to 100%. 2. Continue hand ventilation. 3. Ascertain the correct position of the endotracheal tube. 4. Pass a suction catheter successfully down the whole length of the endotracheal tube. No improvement is seen. What will you do, and what is the cause of the dilemma? Solution: the patient was undraped so her chest could be examined. The epigastrium was seen to be markedly distended. Unknown to the anesthesiologist, the endoscopist had injected air to dilate the esophagus and the stomach for better visualization. With gastric decompression, the patient's respiratory and cardiovascular parameters immediately returned to normal. The case proceeded without difficulty, and the patient made an uneventful recovery. Discussion: this problem has been noted in both pediatric and adult cases. Excess insufflation of air into the esophagus dilated the stomach and markedly decreased chest compliance. The desaturation noted in this case most likely reflected the effect of ventilation, perfusion, V/Q mismatch in a lung being compressed by a distended stomach. Excessive gastric air insufflation has also been reported in neonates with tracheoesophageal fistulas, at times associated with cardiac arrest presumed secondary to the same mechanism. Hence, use of a preoperative gastrostomy tube has been recommended in these cases to vent excess air. This case would not have occurred had the anesthesiologist had the opportunity to observe the child's abdomen. It is not essential to cover patients for non-sterile procedures. Recommendation: the epigastrium must be seen at all times during upper gastrointestinal endoscopy to prevent the possibility of excessive gastric distension. Thank you. Like and subscribe.